we look forward to starting off a little change in order with Dr. Rohit Saxena, who's going to talk on a very important, relevant topic for our country, which is tuberculosis and the optic nerve. So on to you, Dr. Rohit.
Thank you, Dr. Chitra, Morley, for the opportunity, and hello to everybody who's tuned in. Tuberculosis and the optic nerve may sound a little unusual, especially considering the fact that we are discussing such wide variety of disorders which are wide-ranging, which have a lot of other issues also. But tuberculosis, unfortunately for us in India, is such a big issue that I don't think you can ever discuss any problem without having tuberculosis as the elephant in the room being missed. So tuberculosis can result in vision-related problems, and we'll start with vision-related problems. One, by the direct infection or involvement of the visual pathway anywhere along its course. So from the optic nerves right up to the occipital lobe, and we'll see some examples, whether it's tuberculosis directly or tubercular meningitis, direct infection and involvement of the visual pathway can present with sudden visual loss. Tubercular meningitis can present with hydrocephalus with secondary optic atrophies. Direct infection, of course, retrochiasmal will present with primary optic atrophy. Tubercular meningitis with hydrocephalus will result in raised intracranial pressure, which will cause secondary edema and then secondary optic atrophy, and can be a very, very important cause for vision loss. Again, tuberculomas can occur anywhere, and this is the photograph that I'm just showing you. You can see the tuberculomas getting involved everywhere. Here, this tuberculoma is right sitting on the chiasma and causing a compressive oblique direct involvement toxic optic neuropathy. And of course, finally, the most important thing we'll be discussing about is toxic optic neuropathy, which is something that we are all worried about. So we'll just start with a couple of cases, just showing you how tuberculosis can present to us. This 21-year-old female was diagnosed with tubercular meningitis, was being treated with ATT for 3 months, and then 1 week ago she had diminution of vision, and she presented to us. Her vision was very poor, sluggishly reacting pupils, and bilateral disc pallor. Now, 3 months ATT, including ethambutol, your first thought would be that this is toxic optic neuropathy. But because there was neurological involvement in the first go itself, although the initial imaging just showed tubercular meningitis, which was the basis of diagnosis, here you can see a repeat imaging showed multiple lesions. So actually the disease is worsening. And this is the most important thing from our perspective. The moment you're thinking of toxic optic neuropathy, you're actually asking for withdrawal of one or more of the interventions. Whereas in this case, you can see there is a progressive increase, there is a breakthrough on treatment and worsening. And this is an important intervention. Not only are we going to talk about withdrawal of ethambutol, of course, because it is difficult and that can be discussed, but that the treatment should be upped. So it's important to image the moment you have a patient with neurological involvement of the brain or anywhere in the pathway with tuberculosis. So now another patient with tubercular meningitis presented with diminution of vision for 1 month on ATT and prednisolone, had everything else looking normal. Again, an imaging was required. This was a patient with a non-communicating hydrocephalus, and you can see this the widening here, the ooze in the periventricular area, all these showing that there is a raised intracranial pressure. Obviously, managing and upping the treatment is the key for managing these patients. A 30-year-old male presented with recent onset diminution of vision. He was on ATT again, including ethambutol. Recently, ethambutol and INH was stopped by the physician. The vision was 636 in the left and 612 in the right. And when we got the fields done, again, it's the first most important thing to do is the fields. You can see this is the kind of image, the field that the patient had. Again, it's important to get an imaging done, because why he did not have neurological tuberculosis, he had pulmonary COX, but when you see this, you know that there is something else going on. And again, this was a patient with a tuberculoma sitting just on top of the cella, and not all vision loss is due to toxicity. Another patient who had an orbital involvement. So you can see left proptosis, subnormal vision in the left eye, mildly, this is the field, not very clear, but there was a disc edema bilateral, You can see that left eye, there was disc edema. The right eye started showing signs of a little bit of an edema that was developing. Again, an imaging of the orbit showed extensive involvement of the orbit. Of course, this does not definitely show that there is tuberculosis. That shows that there is an inflammation there. The chest had hilar lymphadenopathy suggestive of tuberculosis. He was presumed to be because of tuberculosis and orbital involvement. We started him on ATT and he resolved along with steroids, and he resolved over time. Of course, there was mild vision loss that persisted. Like I said, no discussion on tuberculosis is possible without discussing toxic optic neuropathy. It presents with mild to severe bilateral painless loss of vision. Initially, they may just complain of color desaturation. Usually, they are more or less symmetrical. The patient may not complain of clinical symptoms and may have just subclinical toxicity also, and they may just be incidentally picked up. The fundus may show essentially normal in the initial phases when they present to us, but over time, they will have optic atrophy. They may have central or centrocecal scotomas. OCTs are now becoming important because they can pick up early ganglion cell loss, which can later on translate to RNFL loss also. The other important thing is an increased latency on the visual evoked potentials, which is important. And the other important thing to remember, many studies, including from our center, has shown that there is subclinical involvement in almost up to 50% of the patients who do not actually come with any obvious loss. So it's important that ethambutol can cause subclinical involvement, showing changes in the RNFL in these patients. Besides ethambutol, INH and linezolid has also been implicated now in causing a toxic optic neuropathy, but ethambutol still becomes the first culprit, not only because it is a higher prevalence or incidence of toxicity, but also the fact that with the new regime we'll be talking about, it is almost the most common drug that is being given to patients. Important to remember, there are other causes. So you could have mitochondriopathy or LHON. Sometimes an LHON patient, because of his predisposition to neuropathies, presents early on, may not actually have may not have a presentation of LHON, but because of the toxic insult may present with us. So it's important sometimes, if you're not very clear or the dosage is not too high or too long, to actually look for LHON also. But of course, as I mentioned, there can be a lot of other differentials that we need to rule out. The major change has been from 2016, and by 2018, when this was incorporated, is the major change in the new guidelines, which has now become daily. Now we are giving ethambutol for at least up to 6 months on a fixed dose combination. So it becomes very difficult to advise the patient to stop just ethambutol, because then up till now, on a fixed dose, he's getting free from the government, but now he may have to purchase it on his own because DOTS is not giving separate doses, and therefore it's an important decision that we need to take. The revised program, although there are safety features, but the dose of ethambutol can reach up to 20 milligrams in adults and 25 milligrams in children, those at the lower end of the weight band. There is an increased risk if there is malnutrition, alcohol intake, tobacco abuse, or if there is other comorbidities like diabetes, hypertension, nephropathy, and of course, concurrent use of INH or linezolid. We need to be alert because almost 25 lakh people are on ethambutol in India at any given time. This, of course, were the guidelines we had created, and that resulted in publications. And these are the important things. I'll just quickly run through the suggestions or the advice that we have for ophthalmologists and everybody. It's important to know that the incidence increases with dose and duration, and of course, greater risk in older patients, those with hypertensive, chronic smokers, alcohol, or presence of renal disease. So these are important red flags, and any patient who starts ethambutol on with these comorbidities must be advised to get a regular screening. There is no clear idea about why it occurs, but there is a possible zinc or copper chelating property which results in a damage to the oxidative pathway, and the retinal ganglion cells are particularly susceptible because they have high cellular mitochondrial content. No effective treatment, early detection and stopping is the important intervention. Besides that, you can give vitamin supplementation, including zinc, methylcobalamin, and pyridoxine, good nutrition, managing the comorbidities, and regular follow-up. For ophthalmologists, have a high index of suspicion, opportunistic screening if a patient on ATD comes to you, and as I mentioned, early detection and warn these patients. Most important thing is to increase awareness among anybody who's treating patients with ATT, anyone with high risk who's on higher doses, longer duration, renal impairment, diabetes, tobacco, alcohol, co-treatment with linezolid, pre-existing visual dysfunction. In fact, if patient has pre-existing visual dysfunction, we tend to advise them not to give ethambutol because it can be difficult to pick up early loss. And those with high risk should undergo an evaluation regularly. Ask the physician to be aware about optic neuropathies, and the patient may just be asked verbally if he has any visual complaint. And if he complains during follow-up, the patient should be referred to an ophthalmologist. At a patient level, create awareness. There may be a questionnaire which is possible, especially with the physician, so that he can ask these questions to patients whenever they're coming at the DOT center for follow-up. So again, patients should be advised. We need to notify if we have this. This is the most important thing. It's a responsibility of ophthalmologists and physicians, because even now there is very little reporting of toxic optic neuropathy at an individual or as a hospital level. So essentially, it's important for us to be aware and to be very sensitive to this. As I said, prevention is the best, but we can advise medical supplementation of vitamin. So essentially, there is a huge variety in which tuberculosis can affect the visual system. But most importantly, of course, is ethambutol toxicity, and recently some reports of linezolid-related toxicity, which we should be aware about. Thank you very much again for the opportunity.
Thanks a lot, Dr. Rohit. That was a superb talk for a non-neuro-ophthalmologist like me. So then what would be a quick screening method for ethambutol toxicity, like even before you go on to the fields, like as soon as the patient starts telling you?
So color, one of the most sensitive is color. And of course, from a test point of view, electrophysiology. So increase in latency if you suspect. And of course, contrast also starts getting affected. So higher visual functions or specialized functions like color followed by contrast, visual evoked potentials, and of course, over time visual fields. So these would come in that order very early. And as I mentioned, you can just ask any patient on ATT on ethambutol, can be just asked to be aware of the color of the same thing that he's seeing on a daily basis. So a colored calendar, he just sees every day. And the day he starts feeling that the color is not looking as bright as it normally did, is the earliest sign he would have. And that's the time when he should report to us.
Okay. On to you, Murli.
So have you had any patients with an asymmetric vision loss that may cause some confusion in patients whom you have suspected ethambutol toxicity?
Yes, to an extent, yes. Although not very severe asymmetry, but yes, asymmetric loss has been there. So one eye would be virtually normal. Although again, like I said, color contrast may be affected. The visual loss may not be significant, but one eye may show marked visual loss. So as I mentioned, if there is pre-existing pathology or there is pre-existing, that itself becomes a confounder in this. But yes, asymmetric involvement is known.
In patients with ocular tuberculosis who are on ATT, are there any challenges in identifying ethambutol toxicity? They may have vision loss because of other causes. I mean, have you encountered that kind of a thing? Tuberculosis uveitis.
Yes. So one of the recommendations that was felt by the group and that everybody feels is, or I personally also feel, that if a patient has a pre-existing visual dysfunction, that patient should be preferably avoided, whether it's because of a neurological tuberculosis, whether it's because of the ocular tuberculosis. If possible, we should avoid ethambutol in them, because as I mentioned, catching it early will be a very, very big challenge. So treating physician, including ophthalmologist, may just relate it to the uveitis or to the ocular pathology, while at underlying basis you are having a toxic neuropathy, and then whatever you treat, you may treat the uveitis, but the visual dysfunction will remain. So our advice would be to definitely avoid ethambutol in these patients. And of course, if that cannot be avoided, have a very, very close and sensitive follow-up. And if there is any deterioration in the absence of the disease increasing, that itself becomes a red flag. So a closer follow-up in these patients with visual evaluation. And if there is any deterioration in the absence of the worsening of the primary disease, that itself becomes a very high sign or suggestion of ethambutol toxicity. Thank you.
Yeah.
Thank you, sir. Thank you very much, sir.
Thanks a lot, Dr. Rohit.